So I've been invited to talk about the state of research for pressure ulcers. Now that's quite a daunting task. So what I thought I'd do is I thought I would show you something about the gaps that we identified in the previous guideline, and I'll tell you something about the work that we did in Southampton. So I want to highlight two studies to you. If you visit the presentations in the program over the next 2 days, you will hear a lot about new research, like Jay Nixon is presenting on Pressure 2 this afternoon, which is, of course, new research. So I would like to encourage you to go and listen, because that's one of the largest trials that has been done. And I wanted to start with The Very Hungry Caterpillar. I don't know if this is a famous book here in the UK, but it certainly is among kids in the Netherlands. And in the Netherlands it's called Rupsje nooit genoeg, which means as much as little caterpillar never enough. And I think us researchers get accused of that a lot, because we always say more research is needed. And I wanted to introduce you to these two guidelines, which actually say more research is needed. So this is the International Guideline for Prevention and Management of Pressure Ulcer, Clinical Practice Guideline, that we developed in 2014. We launched it in 2014, and the international group is updating this at the moment, and we will launch an updated version in 2019. Small working groups are working very hard to review all the literature to see what's new. And the other one is the NICE guideline on pressure ulcer management, which I'm sure you all know. Now, going back to the international guideline, when we say more research is needed, that's because when you look at the strength of evidence of recommendations, we have this strength of evidence A, B, and C. And A, strength of evidence, means that recommendations are supported by direct scientific evidence from properly designed and implemented controlled trials on pressure ulcers in humans, level 1 studies. And there are only 6 recommendations in the international guideline that have that strength of evidence. There are 71 recommendations that are supported by direct scientific evidence from properly designed and implemented clinical series on pressure ulcers in humans. And then there are 498 that are recommendations supported by indirect evidence and/or expert opinion. So a lot of what we do in practice and a lot of the recommendations from the guidelines have not been properly researched. And if you look at the ones that are level A, they are about repositioning, they are about reactive foam mattresses, and there's one around electrical stimulation for treatment, and there's one around nutrition. And that's actually the ones that we have trial evidence on. So the guideline also looked at what do we need to do? What would recommendations for future research be? There's a whole chapter on that. And I just printed it. It's 2 A4s with the lists of things that we would want to see researched in the future. Research methods is a very important one, and we've got a meeting on research methods in wound management tomorrow at the REN. It's running parallel to this conference, and that's actually looking at how do you correctly power trials, because we can say we want trials, but trials are quite a challenge if incidence is around 5%. You need thousands of people in a trial, and Jane will tell you all about that this afternoon. Etiology of pressure ulcers, we need more research on that. We know a lot about deep tissue injury already, but we don't know enough about skin failure yet. One of the topics in there. Preventive care, the preventive dressings, for example, is something we need more research on. Pain management. But 2 topics that we have been working on is repositioning and early mobilization, and pressure ulcer prevention and management in special populations. And I wanted to highlight these 2 studies to you.
The first study is work by Marjolein Woodhouse, who was one of her PhD students. She's a postdoc now. She got her PhD, and she looked at repositioning. So the guideline says reposition all individuals at risk of or with existing pressure ulcers, unless contraindicated. And this is one of the level A recommendations. And then it says use the 30-degree tilted side-lying position. So alternately right side, back, left side, and then back to the back again. Or the prone position if individuals can tolerate this. And that's strength of evidence level C. So we know that we need to reposition, but there's not a lot of evidence on how to do that. And Marge looked at actually when we do the repositioning, because of course reposition is part of all of our protocols. So when we do it, how do we do it? Does the repositioning technique vary between practitioners? Does it reliably offload? So is it actually effective in offloading pressure areas, vulnerable areas? And does written guidance on how to reposition patients, does that actually improve repositioning? So how do we improve it if it's not good enough? And she set up a before-after study where she looked at, she gave the participants a work experience survey. She asked nurses to reposition a healthy volunteer on a bed and then read the positioning guidance. After the participant had repositioned the volunteer, we did measurements on interface pressures. We looked at what the angle was that the patient was lying or the volunteer was lying in, and we looked at whether there was enough offloading, and we took pictures. And then the participant repositioned the healthy volunteer again after reading the manual, and we repeated the measurements. We had 12 nurses participating in this study, and the majority were RNs. They had a median clinical experience of 6 years. The range was 1 to 36 years, and they were all active in repositioning in clinical practice, and they had attended pressure ulcer training in the previous 5 years. And they reported that included instruction, or 83% had instruction on repositioning included in that training. But when we looked at the repositioning and we looked at offloading of the sacrum, the heels, and the malleoli, that was actually infrequent, and there was a lot of variability in how this offloading was achieved. So the turning angles were very different. We did see an improvement in the turning angles. So the gray boxes are before reading the instruction. The white boxes are after reading the instruction. And you can see that there is a lot of, so the higher the gray bar, the more variability there is between nurses. So there was a lot of variability in the beginning. And there was that got better after instruction, and particularly on the I can't read it. I need these glasses now. On the ankles, there was a lot of variability because we talk about heels, we talk about sacrum, but we don't talk about the ankles a lot. But when we looked at the photographs, that actually shows much better what this graph just showed. The top 4 photographs are pre-test repositioning technique, and the below ones are post-test. And what you actually see is that the healthy volunteer is all over the place. Nurses reposition that patient very differently. So we ask them to put him in 30-degree side-lying position twice, before and after instruction. And you can see that the legs are positioned very different. Some have paid a lot of attention to offloading heels, others haven't. So there's a lot of variability in this. Now, is this strange?
Well, actually not, because if you look at the instructions that are out there in the guidelines, these are the pictures that we see in the guidelines, or the pictures that we see in articles. So actually, it is very difficult to reposition someone if your instructions are unclear. So giving instructions does help, but they need to be clear too. I can't imagine that photograph B would be a comfortable position to be lying in, by the way. I don't know. So practitioners should be provided, was her conclusion, with practical training surrounding patient positioning for pressure ulcer prevention. And it has to be very visual, because that's what nurses, so we need to provide visual training material. And guidelines should provide unambiguous instructions on what the position should look like. So that was repositioning. The next study I would like to present to you is on special populations. So Hannah Liversedge is one of our PhD students, and she looked at skin damage in neonates. Now we know that adults develop pressure ulcers, and we know that what the prevalence is, but actually skin damage is one of the most common iatrogenic injuries occurring in 24% of neonatal intensive care patients, so neonates. And literature has reported several mechanisms. So diaper dermatitis, taping, so tape stripping, extravasation injury, thermal injury, and pressure ulcers. So neonates can develop quite a lot of forms of skin damage. So what Hannah wanted to do was look at all of those, because we know that prevalence rates are as high as 23%, that they are often related to equipment and devices. Only 50% of the pressure ulcers in neonates, equipment and devices are implicated. An example of that is CPAP masks, which can really damage the face of the neonate. And the high incidence of trauma has been correlated with low gestational age. So the younger the baby, and the lower the birth weight, the more vulnerable their skin is, the less developed their skin is. So the more vulnerable they are to damage. Sometimes this even results in the need for cosmetic surgery, because children lose part of their nose, for example, or part of their ear because it gets so damaged. Of course, there's all these competing demands, right? Because we want to keep these children alive, so we need the devices, but they also cause a lot of damage. Now, what Hannah did is she looked not only at pressure ulcers, but she looked at all the skin damage, because we wanted to know what the extent of that was. So she did a prevalence study first. Now, prevalence is looking at how many children have a wound or have skin damage at a certain moment in time. She collected data at 2 neonatal intensive care units over 2 days. She recorded all forms of skin breakdown and recorded demographic information and detailed information about care. So this is the data collection form. We adapted it from the data collection form that is used for adults, but of course not all the issues were relevant, so we made our own. And the results were that we found there were 32 babies or 32 neonates observed during data collection these 2 days. 50% had at least one instance of hospital-acquired skin breakdown. 16 of the 32. And 50% had skin breakdown associated with medical device use. So 8 of these 16 children had medical devices. Medical devices were linked to the damage they had. And these 16 patients had 23 wounds or events in total. What were the causes of this skin damage? Well, diaper dermatitis, 13%, skin irritation, 13%. There was some delivery trauma, 9%, But medical device-related pressure ulcers made up the largest part. And one of them was quite interesting, was an umbilical cord clamp, which had caused damage to the skin, but also ECG leads and nasogastric tubes. We didn't see a lot of CPAP lesions, but that's because this intensive care unit just changed from CPAP to a different technique, so they didn't use a lot of CPAP masks. We also looked at incidence, because incidence is looking at how many children acquire a pressure ulcer while they are in our care. So same two neonatal intensive care units, data collected over 3 months, primarily during the medical ward rounds, twice a week, from September 2016 to April 2017, so quite recent. Again, all forms were recorded and demographic information and detailed information about care was recorded. The average gestational age of the infants was 28 and 29 weeks in the two hospitals. And these were the medical device interventions that were used. So what you can see is a lot of, there was some CPAP use, but NGT tubes were used a lot. Urinary catheters weren't used, SPO was used. So a lot of devices that are very common, and most children had more than one device fitted on them. This is not saying that all these devices caused skin damage, but these were the devices that were in use. So there are a lot of devices that we use on these tiny babies. Skin damage in total was 65% on site 2 and almost 50% on site 1. That means that that's the incidence, that's the number of babies that develop a pressure ulcer or a skin damage. Pressure ulcers were 25 or almost 26% and 37.5%, and device-related was 28.5 and 35%. There was on site 2 one chemical incident, which was a burn caused by fluids. So skin damage is observed in over half of the infants we studied, in both the Prevalence Study and the Incidence Study, predominantly associated with dermatitis and pressure ulcers. Medical devices are observed to be the cause in at least half of these. So we really need to do something about medical devices. And tomorrow there is a whole session on medical device-related pressure ulcers, at which we will be presenting a little bit more of the results of the research that we're doing on that. And the majority of injuries occurred in infants under the 30 weeks gestation. So that means that the infants with really vulnerable skin. So our challenge is that neonatal devices need to be fit for purpose. And we really need to look at a bottom-up approach and look at the skin function of neonates. We don't know a lot about the skin and how to protect the skin. We need more education. We also did some surveys and some focus group interviews, and actually nurses on these wards recognize there is skin damage. They don't necessarily call it pressure ulcers, and we found that TVNs are hardly involved on neonatal wards because a lot of these nurses solve it themselves, so they teach each other how to treat these. We need to lobby key agencies to change the materials that they make their masks and their products from. And we need more research. So more research is needed on these both two topics, but on pressure ulcers in general. And of course, being the past president of EPUAP, I can't resist Tina, so before you hit me with a stick, she threatened to hit me with a stick and the light is already red. 21st to 23rd of May, we've got a focus meeting on intensive care related pressure ulcers. And of course, we've got our 20th annual conference in Rome this year, 12 to 14 September. So we hope that us being in Rome might seduce you to visit the conference. Thank you very much.